And you're listening to WVOE. It's time now for Health Facts with Dr. Brown.
All right. Thank you for that introduction. It's always good to chat with the folks down in Chadburn, North Carolina. Good afternoon, listeners. You're locked into WVOE, the voice of Ebony, where your health is our heartbeat. I'm your host, Dr. Christopher Brown, president and founder of PressureMDAcademy, welcoming you to another enriching session of Health Facts, the show where wisdom meets wellness and knowledge is always in season. All right. So we're about to do episode 3. Of our kidney series. So this one is when kidneys fail, understanding treatment options and taking control. So for the last couple of episodes, we've been talking about kidneys. How important the kidneys are. We started out with explaining what the kidneys are, kind of what their function is. So we went over that. We went over some statistics about kidney disease, and then last week we talked a little bit about how to monitor your kidney function. The EGFR, that kidney number, how important that is to tracking your kidney function and empowering you to know when your kidney function is decreasing, when it's staying the same, what that means. How to ask questions whenever you go to your doctor and they're monitoring your kidney function. Okay. Also talked a little bit about the albumin, how important that is, the fact that it's a marker for your kidneys getting worse and you want to keep that under control. So we talked about that a little bit last time as well. So this episode is kind of dedicated to, what happens when your kidneys fail. Okay. So, we're always talking about being aware of issues different health issues. And then we also talk a little bit about, how to monitor those health issues, how to slow things down. And we mentioned that a little bit last time. But, for a lot of people, what's going to happen is that, especially when it comes to kidney disease, the problem that's going on, whether it's hypertension, diabetes, or some other cause of your kidney disease, may continue to damage that kidney. And if that happens, even though you may check off all the good patient boxes and do the things you're supposed to do, and you might slow it down, but at some point in time, that kidney just can't sustain life, basically. And that's what we call end-stage kidney disease. And that's, when that kidney can't sustain life, when, electrolytes are going awry, a person, it's got to the point they got a lot of fluid on the either legs or sometimes the lungs. And so this is what we call end-stage kidney disease. And so this episode is really kind of dedicated to understanding what happens when this goes on and then understanding treatment options. So because that's the big things with this is understanding what does it mean when your kidneys fail. Okay. So end-stage kidney disease, what we call ESRD, the R is for renal. So we used to say ESRD, now it's ESKD, and basically end-stage kidney disease. That means when the kidneys are working less than 10 or 15% of their normal capacity. So the EGFR that number has dropped down to less than 15, and then also you're having these other issues that are going on there, and really at that point the body can't clear the toxins or balance fluids on its own. So maybe one, it may be both, and so that a person will need something what we call renal replacement therapy or kidney replacement therapy. Basically, those things when we talked about what the kidney does in the first episode, these machines or these devices or methodologies are designed to replace what the kidney was doing as much as possible. Of course, you can't be the original, but like I said, this is a way to kind of replace that. So you're replacing kidney function with either a modality called dialysis, and we'll talk about that a little bit, or a kidney transplant. Okay, we'll touch base about that as well. And so one of the things that like I said, this is of course education. It's not medical advice, but it's education and empowerment. And so one of the things that's really important about this stage is that if you preparation really helps you to adjust to this stage. There's nothing that I think is more, for my personal professional experience, that's sadder than when someone comes in and especially in the hospital, and I have to start them on dialysis, and they had no idea. Okay, so you come in for one problem, maybe you haven't seen either you haven't seen anybody in a medical field for a while, and come to find out your kidneys are they're really gone, and we have to put you on dialysis, and that's a it's a shock to a lot of people, because this is I mean, in order to survive, you need to do this process, and that process is really involved. Okay, so a lot of people, and we'll talk about dialysis a little bit, but like when you're on dialysis, you're talking about 3 to 4 hours, 3 days a week that you're attached to a machine. So what you can do though is you can prepare long before that stage happens, and then we're going to talk a little bit about that, and talk about how to be the best member of your kidney care team. Okay. All right, so let's talk a little bit about some of the kidney failure numbers. So basically, about 800, and this is according to U.S. Renal Data System 2024 report. So about a little more than 850,000 Americans, okay, are living with ESRD, and so about 500,000 of those were on dialysis, and about 250,000 are living with a functioning kidney transplant. Okay? Now, I always like to pull out a few statistics. So, although African Americans, Black Americans make up about 13% of the U.S. population, they represent more than 35% of people on dialysis. And for Black men, they're nearly 4 times as likely to experience kidney failure than white men. The average time from diagnosis of CKD to dialysis is often shorter for African Americans. And some of that is the disease progresses faster, but also there's an issue with diagnosis and referrals. So, like I said, whether or not you get diagnosed with the kidney disease, uh, and also when you're referred to the kidney specialist. So sometimes that stuff can happen later, and so that's why you all are tuning in, so so that you can uh, learn how to get your CKD diagnosed early, and that's why we talk about the screening, and then also that that if your primary care is following you, you know when to get yourself referred, or you can request referral at an earlier stage. Okay. But we can change some of the stuff. Like early preparation really helps with when you get diagnosed with end-stage kidney disease. You want to know this stuff ahead of time. Okay, and so when people who meet with a kidney team before they reach kidney failure, they're more likely to start dialysis safely. They're more likely to choose a home therapy, and twice as likely to receive a transplant within the first year. And so when we mention this, what we're talking about is, kind of like I mentioned with the person that starts dialysis in the hospital and didn't know they even had kidney disease. These people have to get catheters, which are known to increase your risk of infection, as opposed to what we call a fistula or a graft, which are known to be safer. Home therapies, you can actually do dialysis at home. And that's easier to do if you know that you're going into this, as opposed to, yet again, you walk into a hospital, you go into a hospital, and then all of a sudden you start. And it's kind of hard to start a home based kidney therapy if you are just now finding out that you even have kidney disease. Okay. And then the transplant, like I said, you can increase the chances of you getting a transplant within the first year or two, because if you know that you have kidney disease and you're preparing, you can get on that transplant list a little earlier. Right. Okay. So preparation for end-stage kidney disease starts before your kidneys reach that 15 mark, or that 15% mark. Okay. So technically speaking, you actually start preparing in stage 4. So stage 5 is when you really kind of get on dialysis. Stage 4 is when you really start preparing. You start to learn about your treatment options. Yeah, you should have. If you haven't met with a nephrologist, you should definitely meet with one by stage 4, and the nephrologist and your kidney care team, and start planning for access, and whether that's a fistula, early transplant evaluations, and or a graft. These are things you can do whenever that EGFR is below 30. And so this is where you become your own advocate. And so we want to prepare early so you can continue to preserve kidney mass longer, and delay the need for dialysis. And that's what this whole conversation's been about. And that's what this whole show and part of what I do is because, technically speaking, because sometimes people are like, well, no one told me, or no one told me that my kidneys were decreasing, because a lot of times, you your clinician may not be aware, at least until recently, that you had kidney disease, because it used to be that your EGFR was not reported until it was less than 60. It was greater than 60, you just said greater than 60, and they didn't really give you a number. So like I said, recently they let you know, so you can tell the difference between when your kidney number is 80 versus 70. And so you can kind of watch it a little bit more there. And like I said, and now we can move into a world where we are preserving that kidney mass at, say, 55, as opposed to waiting until the kidney mass is at 30. Okay, so we're moving in that direction, and that's one of the reasons why we want to empower you to know what's going on here. Okay. So they have studies that show that when patients begin kidney education programs at stage 4, okay, and that's the stage right before the dialysis stage, they can have 20 to 30% slower progression and fewer hospitalizations when they do start treatment. So that could be the difference. So if we start at stage 4, that could be the difference between you having to go into the hospital to get started on dialysis versus you being able to go from your home or regular routine to starting dialysis, inside, even if it's inside a facility, you can get that done there. So knowledge isn't just about power; it's protecting, it's protecting you, it's protecting your kidney, it's protecting in some ways your way of life. Okay, so that you have fewer disruptions. Okay, so now we talked a little bit about dialysis, touch base about dialysis. So we touched base about dialysis. We already talked about it. So we want you to understand what dialysis is and a little bit about how it works. It's actually fairly complicated. So dialysis is a treatment that they like to say it replaces what your kidney does. It is a good substitution for what your kidney does. It can keep you from dying from the majority of kidney functions that are failing. Okay, but it doesn't completely replace the kidney. All right, nothing is like the original, but it does a great job. It does a good job of removing waste and metabolites that our body naturally produce, and it removes extra fluid. It can balance electrolytes and keep your body in a chemical balance. And so that's kind of what dialysis does. That's the main thing it does, is it replaces the critical functions of the kidney, and that's what it does. Okay, and there are two main types of dialysis. There's one called hemodialysis, and this is the one that most people are familiar with. And this is where we get access to the blood. It's sent through a machine and really a filter, and that filter kind of takes it balances out your electrolytes, takes a lot of the waste off, and it removes a lot of the fluid. And that's what we call hemodialysis. The access is usually gained through a catheter, which I tell people it's kind of like a big IV, and it goes in either the neck or the groin area, or is done through what they call a fistula or graft. And a fistula is like a special, I call it a super vein. They can do a surgery to create what is basically a super vein. It'll be a large vein, usually in the arms. You can't form them in the legs, but usually it's in the arms. And you can access you can access blood and send it through the machine through this thing called a fistula. And then there's also something called a graft, which is an artificial super vein, if you want to call it that you can use to also do the same thing as you do with a fistula. So we try to, as much as possible, you try to avoid getting the catheter because they are sources of infections. Also, there's certain things you can't do when you have a catheter, like take a shower. So if you have a fistula graft, you can take the shower. If you have a catheter, you really can't, or you have to really tape it off and make sure that it doesn't get wet. Okay. So now that's the hemodialysis part. Hemodialysis is typically done about 3 days a week in a dialysis session in a dialysis center. Each session is typically anywhere from 3 to 4 hours long. They do have the option for what we call home hemodialysis. So home hemodialysis, they actually have a machine. So when you go into a center, there's like this huge machine there, but they actually have with technology, they actually have a much smaller machine that you can actually take home and do the same or very similar treatments at home. It usually adds a little more flexibility, and for a lot of people, better quality of life, because you're at home as opposed to going to a center. So that's the hemodialysis part. So hemodialysis is the one most people are familiar with. It accesses the blood, and it takes extra water out and also does balances your electrolytes, right? So that's hemodialysis. So that's the one that most people know about. The second one is what we call peritoneal dialysis. And this is interesting because most people don't know this, but in your abdomen, of course, everybody knows the intestines and stuff are in there, but there's actually a lining. It's almost like a little pocket that's in there, and because your intestines are actually covered by a little special membrane, and there's also one that covers kind of your musculature that's in your abdomen, and there's a space in there. And what can be done is that you could put a catheter in that space. You can infuse fluid into that space. It'll fill itself up. Leave it there for a little while. And what'll happen is that the same thing that goes on with the filter with the hemodialysis will happen in that space with that fluid there. And so, you can actually take extra fluid off of a person. You can actually balance some of the electrolytes off of a person through this it's a little pocket. It's in the belly. So now peritoneal dialysis is something that's done at home. So you really, really you have to do it at home, because what happens is that you traditionally you'll put fluid in there, you let it do what we call dwell for a little while, and then you'll drain it out, put some more fluid in there, and then you kind of do the same thing. You do that for another couple of hours. So that's the way it traditionally was done. Now they do have something called a cycler, and what this cycler does is that you actually attach yourself to the machine, set it up for hours. Most people do it at nighttime. And the machine will do this. So while you're sleeping, it will put the fluid in, let it dwell for a period of time, drain it back out, and then infuse it back again. So yes, so you're just doing this while you're sleeping, and that's how. And those people don't have to go into the center unless there's a complication. You usually check in with your nephrologist about once a month, and you do a lot of this stuff at home. Now, PD really allows you a lot of flexibility, a lot of independence. You can travel with PD. So if you say, hey, you know what, I'm going to go to Florida for the next 3 months. And what you do is you can arrange to have your materials sent down to say Miami, and you'll just do the same thing you were doing at home at wherever you're staying in Miami, whether like Airbnb, hotels, whatever. Now, one thing you do have to do is you have to make sure the area is clean. But you can do that with that. You can do it if you had a camper. You just have to make sure you got access to your supplies, and you can do that. So that does allow a person to get a lot of flexibility, a lot of independence, and a lot of times, and some people think it's a lot gentler on the body as well. Okay, so both of these are the two main types of dialysis, and it's something that people really need to know about before you need this, so that you know that you have options. Because really the default option is for people to go into the center, but educating people about these other options, you can decide what fits your life better. Okay, all right. So that's the thing. The other thing that becomes important in this, no matter what type of dialysis you're choosing, is the access. So when I was talking about the catheter, fistula, grafts, that's what we call your hemo, especially your hemodialysis access. You have to protect that. If you do peritoneal dialysis, it's a catheter only, and that access also has to be protected. You have to keep it from getting infected. So that's something that's always important. So that's it. Okay, it's because it's your lifeline. All right. So now we've talked about dialysis. Okay. So we talked about end-stage kidney disease. The fact that you want to know about things and learn about this earlier rather than later, and that you want to prepare for this. We talked about the two main types, ways of replacing the kidney function. And so one we talked about was dialysis, and that there are two different types of dialysis. Now we're going to talk about transplantation. So transplantation is the gold standard. Why? Because you're getting another kidney. So as good as dialysis is and can be, the transplant is the gold standard. Because one of the things that happens even with dialysis is that people on dialysis still experience increased mortality, because, like I said, it's not replacing the function of the kidney. But people with transplants, after you have to go through a period where you have to make sure you don't reject and get everything stabilized. Their mortality rates reapproach those individuals that did not have kidney, didn't have kidney failure in the first place. So it really kind of replaces a lot of this stuff. All right, so let's talk about the what we call the best option for people with kidney failure, and that is a kidney transplant. Okay, so so the two sources of your kidney transplant, well, you can almost say three now, but okay. So the two main ones are going to be from a living donor. That means a person who has two healthy kidneys, and is willing to donate one while they're alive. So you can do that actually. And then of course, deceased donor. And this is where someone passes away, and they have agreed to be an organ donor, and that individual, and you receive one of those kidneys. Okay. Now, third, you all may have heard about on the news, and that's where you're doing the pig kidneys, and that's being used as a transplant. That's still experimental, so you can only get that done at an academic hospital and probably part of a research study. But that is coming down the pipeline. And then they're also talking about artificial kidneys, but all that stuff is experimental. So the two main ways to get your kidney replaced with a kidney transplant is going to be through living donor. That's where a person that's alive is generous enough to donate their kidney, or a deceased donor, and that's where a person that has passed away is, has agreed to become a organ donor. You get that, okay? So, on average, people who receive a kidney transplant live 5 to 10 years longer than those who remain on dialysis. They tend to have better energy, appetite, freedom. Of course, you don't have to do the dialysis stuff or anything of nature. Okay. Now, the living donor transplants tend to have the best results. These kidneys can come from a friend, they can come from a family member, a community donor. So yeah, so a lot of people are unaware of the fact that yes, you can get living donor transplants from people that are not related to you. The process is they have to get tested to make sure that you don't reject it. But if you are a match, that person can donate their kidney. Sometimes they actually do things where it's kind of hard to describe over this video, but it's actually, so if you know a person that is willing to donate, but they're not a match, and somebody else knows a person that is willing to donate, but not a match for them, but they're matches for the other person, you can actually get people to kind of donate. It's kind of a little more complicated, but there are ways to do that. So one of the things you want to look for is to see whether or not you can get someone, if you are facing kidney failure, to see if there's someone that you know, or sometimes even strangers that are willing to donate a kidney to you. Okay. So other things about the living donor transplants, they usually last longer. They usually start working right away, and then of course the surgery tends to be is safe. Of course, anytime you're going for a procedure, there's always risk. But the living donors usually recover in a few weeks and live full healthy lives with one kidney. Right? So, and then the deceased donor transplants are from people who chosen to donate their organs after death. And the waiting time for these, though, can be vary by region, but they can typically range from 3 to 5 years on average. So it's not a short period of time; it's usually pretty long. So the earlier you get referred to a transplant center, the sooner you can join the waiting list. And the thing is this: you can be referred to a transplant center before you need dialysis. So usually when that kidney number is less than 20, that EGFR is less than 20, you can get referred to a transplant center. Because the other thing is this: the process of getting on a transplant list is actually pretty long. So you want to get on there sooner rather than later. And then once you get on the transplant list, they can kind of watch, see how that kidney function is doing. Okay. But it is possible that you could get a transplant before you go to dialysis. But the thing you have to know is that you'll have to ask, a lot of times you'll have to ask to be referred for that transplant center. Okay. Okay. So, and kind of like a lot of other things, we're disproportionately affected. We're less likely to be referred for transplant evaluation early, and less likely to have potential living donors approached. But when we close those gaps, the outcomes, they really do equalize. And one of the things, and this is one of the reasons why I do like to mention, getting referred for transplant early, and that is because I've known a number of people that have not that just are not aware of this, and one of them was a family member of mine who got a transplant, and we were just kind of talking at one time, and I just mentioned that, and they mentioned that no one had ever mentioned it to them. No one ever talked to them about that. And so just know that, like I said, that if you have chronic kidney disease, your kidney function drops, that EGFR drops below 20, like I said, you can request to be referred for a kidney transplant evaluation. And what they do, like I said, they'll do the referral. Is usually, you usually have to wait months before you can get an appointment and get that process started. But you want to get that process started, okay? Okay, so that's kind of there. And then so that's kind of talking about kidney transplant in general, or end-stage kidney disease management in general. So we talked about dialysis. We talked about hemodialysis versus peritoneal dialysis. And hemodialysis, you got home versus in-center dialysis options. And then for those that want transplant, living donors versus deceased donors, and getting referred early. Before you even need the dialysis, so getting referred when that eGFR is less than 20. Okay, so that's kind of a summary of what we got so far. So now, all right. So we've talked about all this, and yet again, one of the things we want you to do is to be aware of the fact that you need to be very proactive. That you need to, kind of educate yourself. So when you get these diagnoses, you want to learn as much as you can. You want to be, in conversation with your healthcare clinicians and your doctors, so that you can have conversations and know what is best for you and how you want to go about it, and also what are the consequences of you making certain choices. I mean, like I said, your kidneys can fail and you say, I don't want dialysis. And I've had people say that, hey, I don't want dialysis. And until I explain to you that, well, you have the right to refuse, but do you understand that if you don't do this, you're going to die? And then they're like, oh, what do you mean I'm going to die? Well, yeah, the reason I'm offering you this to you is because your kidneys are failing. So this is what I want people to understand, is that I want you to understand this process before this stuff happens. I want you to that stuff to be in your mind, so you can be so you can be a knowledgeable part of your kidney team. So speaking of your kidney team, so who is the most important person on your kidney team? So we got nephrologists, so these kidney specialists. You got nurses. You got dialysis techs. They're dietitians, social workers. You even got your primary. I count the primary care as well. All is part of your kidney team. So who is the most important? Okay. The most important part of your kidney team is going to be you. Okay, so you are the most important person on the kidney team. So, and then when I say this, it's because yet again, this is you. This is your body. You're protecting yourself not only for longevity, but also so you can live better and live well. Okay, so you are the most important part. So you want to be in communication with the nephrologist, with the dialysis nurses, with the dialysis techs, with the dietitian, with the social worker, with your primary care. You want to have that conversation continue to go on even as your kidneys fail, because it becomes, honestly, even when that happens, it becomes even more important for you to engage a little bit more and to understand more stuff about your body, about your life, and what your options are. Okay. So ask questions, understand your lab results. This actually becomes even more important for people that wind up on dialysis, because your labs will be monitored on a regular basis. At the very least, once a month, you're going to get labs. They're going to have all these labs that are out there. So you need to understand what is the importance. People are going to talk to you about your phosphorus, and it's like, okay, why is phosphorus important? Because there's some certain things that happen to you that are negative if your phosphorus is high, and so we got to get this under control. And so if you've already been used to following your labs before, it makes it a lot easier to just transition to following a few other labs. So this is why we want to get you in this space early. We want you to get you wise about your body and what's going on there, so you can take care of those things. Okay. So, all right. So I know this is a lot and it's pretty complex, but it's really important that you understand this. Hopefully, this conversation, or I guess this talk, is a little bit more important. And like I said, even though I'm not your specific doctor, like I said, everything that I'm saying here is not medical advice. It's not direct medical advice, but it's to educate you and empower you so that you can understand what things are important, what things to ask about. So that's what this stuff is. So it's not direct medical advice, but it's a way to kind of help you advocate for your own health. Okay, so here's what we can do as families, as individuals, as families, churches, fraternities, sororities, community groups. If we want to change this story in terms of what's going on with your kidneys, we want to change our narratives. So it's no longer about, oh, I don't even want to get this stuff tested. It's like, no, you want to get yourself tested. You want to get tested early. You want to get, you want to get your labs. You want to understand what's going on with your labs. At least the basics. It don't have to be in depth. I mean, don't get me wrong. When we order labs, there's a lot of stuff on there, but at least understanding what certain things are that are on these labs. You want to get tested. You want to get referred early. Especially if you have like a family history of kidney disease, you don't want to wait to get to a nephrologist. You want to get to a nephrologist early rather than later. So you want to make sure you get that stuff done. You want to talk about kidney donation. You want to normalize that conversation. Why? Because, like I said, because you may need a kidney, but you may find that you want to donate a kidney, and either while you're alive, or hey, even the conversation about what happens if you were to pass. Do you want to have that kidney done? Do you want to donate your organs? That conversation needs to happen earlier rather than later, because no man knows the time. No man or woman knows the time that you're going to pass away. So you want to normalize these conversations, and then you want to support those that are living with dialysis by offering rides, meals, conversations, company. Make sure that, hey, look, if they can't go to things because either they're in dialysis, or sometimes people feel really tired after that. But make sure that they're included. Give them a call, send them a text, make sure they're doing okay. So let's do that from a community perspective, so that these medical issues, this kidney issue, is addressed on a holistic basis, so that individual doesn't kind of withdraw and feel like they're alone. You want to make sure that you're kind of making some accommodations. The other thing that might happen is that, hey, we got, we're having a potluck at church or whatever. Let's make sure that we got some kidney safe foods that are in the potluck. Let's make sure we bring some stuff with low phosphorus, or low potassium, so that people that have kidney disease have options that they can eat that are there. Okay, so let's make sure that we, from a community perspective, that we kind of change that paradigm of how we approach health, how we approach how we address these health issues, and let's just kind of normalize that type of stuff. So just letting you know, kidney failure is not the end. It's a new chapter that you can plan for, that you can empower yourself to engage in. So you want to make sure you're doing that. If you have other questions, feel free to reach out to us on social media. You can also go to our website. PressureMD.com is kind of the clinical aspect. We also got d.brown.com, which is more the education and advocacy aspect that's there. You can also follow us on PressureMDAcademy, our YouTube channel that's there, and feel free to send us a message. Let us know how we're doing. Let us know how we can help, and we'll kind of go from there. All right. Thanks for tuning in, and we will talk to you again next week.